Hello, good morning. This is Dr. Eric Bricker, and thank you for watching A Healthcare Z. Today's Friday training session is the financial implications of Ozempic, Wegovy, and Mounjaro. So, if we could do a audio and video check, if you were on either LinkedIn or YouTube, if you can go to the comments, and if you can just put in if you can see and hear me okay, that would be great. I want to also let you know that during the course of the presentation, if you want to put in questions and comments, again, on LinkedIn or YouTube, please do so, and I will answer them throughout the presentation or at the end, or if I don't get to them, I'll answer them in writing afterwards, as always. Now, if I could ask you a favor before we get started, if you could please either like or whatever the symbol is on either LinkedIn or YouTube, that would be super helpful if you could do that so that we can share this with as many people as possible, because this has been an incredibly popular topic and not everybody can tune in at this time live. But if it gets a lot of likes, then it'll show up on their feed so that they can watch it later. So let's get into the financial implications of Ozempic, Wegovy, and Mounjaro. Now, of course, many of you know me, but for those of you who do not, I'm Dr. Eric Bricker. I'm an internal medicine physician, and before I became a doctor, I used to be a hospital finance consultant. I then went to the University of Illinois in Chicago for my medical degree. I then went to Johns Hopkins in Baltimore for my residency. I practiced as a hospitalist physician at a Baylor Associated Hospital in Plano, Texas, which is a suburb of Dallas. I started a healthcare navigation firm called Compass Professional Health Services, and we grew that business to over 2,000 employers and 1.8 million people that we helped navigate their health insurance and the U.S. healthcare system for 11 years. And it was an amazing experience. We then sold that business to Alight Solutions in 2018, and I did so much education of employers and broker consultants and other folks in the healthcare ecosystem while I was at Compass. I'm like, well, let me keep doing that in the form of these videos. So that's why I started A Healthcare Z, which you can subscribe to on YouTube, or you can just watch my videos on LinkedIn, what have you. And I'm now also the medical director for Simple Pay Health, which is an alternative health plan. Now, we need to start off by talking about obesity in America. If we're going to talk about weight loss medications, we have to talk about obesity in America. So many of you are already familiar with this map, which shows the obesity rate in 1987, very low. In 2003, higher. And now in 2021, the most recent year we have here, it's spread all across the country. So in other words, obesity rates have tripled in a generation. Like, just since the 80s, obesity has tripled. Now, again, on a timeline, this is obesity rates for men and women by different age cohorts, right? So you see all these lines. Look at that. All these lines are horizontal. The obesity rate was the same. And then all of a sudden, it just starts going up. Look at that. Coincidental. Everything starts going up at the same time in the late 1970s. What in the world happened in the late 1970s? Did we all of a sudden have some sort of like moral collapse where we just became a gluttonous society, that after tens of thousands of years, all of a sudden gluttony just became this huge problem in America? No, I would argue that probably did not happen. Did we have some sort of genetic mutation? All of a sudden, our bodies just genetically alter. It's like having 6 fingers on a hand. All of a sudden, we just genetically mutated so that we all just became obese. No, of course not. So Dr. Robert Lustig, who many of you are familiar with, who is a pediatric neuroendocrinologist at UCSF, argues this is an exposure problem. What happened was, one, high fructose corn syrup was invented in the 1970s. It did not exist before the 1970s. So the introduction of high fructose corn syrup, and at the same time, fat and cholesterol were thought to be the huge evils in food. And as a result, cholesterol and fat were replaced in food with sugar. So high fructose corn syrup and sugar are highly addictive substances. They stimulate dopamine in your brain just like cocaine does, and it causes you to want more. It causes you to want to eat more. So this is not a full presentation on why and how sugar and high fructose corn syrup have caused the obesity epidemic in America and the world, but it is super important when we talk about Ozempic and Mounjaro and Wegovy to understand this. Now, let's start off with Ozempic, okay? Huge buzzword, literally, like, people were just randomly talking to me about this yesterday. I didn't bring it up to them. They brought it up to me. So Ozempic is semaglutide, okay? It comes in dosages of 0.25 milligrams, 0.5 milligrams, and 1 milligram. It is a subcutaneous injection. I'm going to show you a picture of the pen that on a later slide. Now, you inject it once a week into your skin, like on your arm. It's made by Novo Nordisk, which is a Danish. It's a Denmark company. They're actually huge makers of insulin, and so now they also make Ozempic semaglutide as well. It was approved for the treatment of type 2 diabetes in 2017. So it's been around for, going on 6 years now, and it lowers the hemoglobin A1C because, of course, that's the goal for diabetes medications, whether it's metformin, et cetera. And it lowers hemoglobin A1C by 1.6%. But it was also found to lower weight, and on the original studies, it was found to lower weight by 10 to 13 pounds. Okay, how does this happen? Why does Ozempic cause weight loss? Does it magically cause us to just burn calories? No, it does not. And oh, by the way, so Ozempic is a GLP-1 agonist. You might hear about these GLP-1 agonists, okay? It's glucagon-like peptide. It causes your pancreas to secrete more insulin. That's its, quote, mechanism of action. But it does something else to your brain. At higher doses, at the 1 milligram dose, it causes appetite suppression, okay? Now, Ozempic to this day, is not approved for weight loss. It's approved by the FDA to treat diabetes. Oh, by the way, it just happens to cause a 10 to 13 pound weight loss as well, but it does it through appetite suppression. Okay, so this gets us to the graph and the map that I previously showed you, okay? So, it's important to remember, matter can never be created or destroyed. So if we're literally adding mass to our bodies, it needs to be because we are ingesting matter. We are literally eating the weight that comes into us. So in order for us to lose weight, we need to ingest less matter, okay? So Ozempic works by helping people eat less. Okay, that is its mechanism of weight loss. So you cannot use Ozempic and eat the same. You cannot. Okay, the studies that were done with Ozempic were done in conjunction with a 500 calorie per day deficit for people. They had to eat 500 less calories per day. Okay, it was never done with, hey, take Ozempic and you just keep eating what you normally eat. Absolutely not. It was also done with doing 150 minutes of exercise per week. So that's 30 minutes of exercise a day, 5 days a week. So just know, this has never been studied with, hey, just take Ozempic and go about your business. That is not how it works. You have to eat less as well. Now, sales, huge, $9 billion in sales in 2022. It is by far the biggest seller for Novo Nordisk. It blows all of their insulin sales out of the water. It is up 77% year over year. So there's a huge increase in Ozempic prescriptions and use nationwide. Now, this is probably, in terms of the financial implications of Ozempic, this is probably the most important bullet I'm going to tell you, and that is, it costs $995 for an 8 milligram pen of Ozempic. And that is the largest, in other words, the most milligrams in a pen. Here's the secret for almost all medications, including Ozempic. The dosage doesn't change the cost of the medication. So these medications, semaglutide, it has to be titrated. In other words, you have to start out at 0.5 milligrams. And then after a while, you increase it to 0.5 milligrams. And then you increase it to 1 milligram. And it takes actually 16 weeks of slowly increasing the dose until you can get up to the 1 milligram. But as you're taking those lower doses, the cost of the pen doesn't change. So if you get to the point where you're on 1 milligram, in order to have the weight loss effects of Ozempic, you need the 1 milligram. So in order to do that, you would have to get 52 milligrams a year. So if you take 52 and divide it by 8, that's 6.5 pens per year. So you take the 6.5 and you multiply it by the $995, then that is $6,478 for a year's worth of treatment with Ozempic. Now, keep in mind, that is, when you're looking at your pharmacy claims, that's probably less than what you're paying per patient per year for Ozempic, because that's the 8 milligram pen, okay? The vast majority of the pens that your company is paying for is probably not 8 milligram pens. It's the smaller pens. So they're paying essentially $995 for less Ozempic. So probably the most concrete thing I can tell you today to help you spend less on Ozempic is have them use the 8 milligram pen. It's like paying the same amount for a half carton of eggs or 18 eggs. Okay, if you want eggs, why don't you get the 18 carton of eggs, not the 6 carton of eggs? So once somebody is on the standing dose of 1 milligram for a prolonged period of time, then they should be getting 8 milligram pens, because that's going to get you the most Ozempic for your money when you are purchasing it. Okay, next up, Wegovy is also semaglutide. It's the exact same medication, but the weight loss effects of semaglutide only work at the higher dosages. It only suppresses appetite at the higher dosages. So they said, hey, let's do an even higher dose of semaglutide in a study. Instead of maxing it out at 1 milligram of semaglutide, let's have 2.4 milligrams of semaglutide. Again, weekly skin injection. So Wegovy is the exact same medication as Ozempic. It's just a higher dose. It's the 2.4 milligrams of semaglutide. Again, made by Novo Nordisk. Wegovy, so the 2.4 milligram dosage of semaglutide, is FDA approved for weight loss. So for people who are obese and have some other medical problem, like high dyslipidemia, so in other words, high LDL cholesterol or hypertension, which again, over 2/3 of people with obesity have some sort of a manifestation of metabolic syndrome, have some sort of metabolic disease to go. So the majority of people who are obese have some sort of health consequence from their obesity. Now, there are some people with obesity who have no adverse health consequences of their obesity. It's called the healthy obese. Upwards of 1/3 of people who are obese are actually healthy obese. They have no adverse consequences of it. Okay, so they had to have some sort of adverse consequence with it as well. Now, believe it or not, they did a study in kids as well, ages 12 and over, and Wegovy has actually been approved for weight loss in kids 12 and over as well. This is a new approval. It was in 2021. So the Ozempic for diabetes was approved in 2017, and the Wegovy was approved in 2021. Again, it works in the same way through appetite suppression in the brain. You have to eat less. Now, it lowered weight by 35 pounds. That is a lot. A lot. 35 pounds is a lot. Now, keep in mind, these people had a starting weight of 232 pounds. So it got them to just under 200 pounds. So I am in no way saying that it's going to get you from 232 pounds. Now, listen, you could be 5'2" and 232 pounds. You could have a super high BMI. And so if you lose 35 pounds and you're 5'2" and you're just under 200 pounds, guess what? Like, you're still obese. So it doesn't necessarily, quote unquote, cure your obesity, but it does lead to significant weight loss. Now, because Wegovy is so new, sales have been 913 million, so far less than the Ozempic in 2022. However, it's rapidly growing. It is up 4x. It's up 400% year over year from the previous year. So while Wegovy sales are lower, they are dramatically and rapidly expanding. Now, here we go. It's priced higher. Okay, so here you've got a 4-pack. So 1 month's supply is $1,432 at the 2.4 milligram dose. Okay, so notice they didn't make it super easy, right? You'll be like, oh, okay, look at that. And it's going to cost me $17,000 if you take the $1,432 for a 4-pack. In other words, a 1 month supply. You multiply it by the 12. The Wegovy costs $17,184. So they didn't make it super easy on the dosing, right? So you could literally save money by just getting the Ozempic and getting the 8 milligram pen of Ozempic. But you'd have to set the dosing so that you were only getting 2.4 milligrams out of the 8 milligram pen of the Ozempic to equal the Wegovy. So listen, the people at Novo Nordisk are trying to make as much money as humanly possible. Like, they're not trying to help you save money. So they are not like giving you the same medication in a way to like minimize how much you pay for it, right? So they've basically packaged it and they've used a dose to maximize their reimbursement. So there is going to cost you 17 grand, over 17 grand a year for the Wegovy. Okay, now there's something you might see commercials on TV that's related to this. That's called Rebelsis, okay, which is also semaglutide. Now it's different because it's a pill. Yes, you can also take semaglutide as a pill. Again, it's made by Novo Nordisk. It's approved for the treatment of diabetes. When I say diabetes here, I always mean type 2. This is not for type 1 diabetes. This is for type 2 diabetes, which of course is the much more common type of diabetes. Now, Rebelsis also lowers the hemoglobin A1C by 1.4%, and it lowers body weight by much less, by 5 pounds, okay? So just know that there's actually a third type of semaglutide as well, the pill type. Sales super high. Look at that, 1.6 billion in 2022. It's up 230%. Year over year. Again, look at the pricing. It's no coincidence, right? It's just under $1,000, right? It's like charging $9.99 for something instead of $1, right? So they're pricing it at just under $1,000 for a 30-day supply. So for the Rebelsis, it's if you take the 995 times 12, it gets you to $11,940 a year for the Rebelsis as well. Pill. Now, just minor medical thing. Whenever you inject something versus taking a pill, when you take a pill, the medication has to go through your liver first because everything you digest passes through your liver first. And your liver takes all substances that are not food, including medications, and says, whoa, this isn't food. This is not normal. And it tries to molecularly alter. It's called the first pass effect. So part of the reason why the Rebelsis just doesn't work the same as the injection is because the liver alters the semaglutide when the semaglutide passes through it. So just know that all pills get altered by the liver, which is why some medications are given by an injection, because when you inject it, it doesn't go through the liver first. There you go. You've gone to medical school today. Okay. Next up, Mounjaro. It's made by a completely separate company. It's a totally different medication. It's tirzepatide. I'm going to say that again. Tirzepatide. Okay. It's in the same category as semaglutide. It's a GLP-1 agonist. It also has an additional mechanism of action as well that I'm not going to get into, but just know that it's sort of more powerful, if you will. It comes in 5, 10, and 15 milligram dosages. Again, it's an injection with a pen similar to the Ozempic. It's made by Eli Lilly, the American pharmaceutical company that's based in Indiana. It is FDA approved right now. It is FDA approved for type 2 diabetes only. It is not yet approved for weight loss. It is most likely going to be approved for weight loss this year in 2023, but it is not yet. It was found to lower weight by more than Ozempic. They actually did a head-to-head trial where it actually lowered weight by 25 to 52 pounds for people, again, starting at 248 pounds. So again, you could be 5'2" and 248 pounds. And when you lose the 52 pounds and you're just under 200 pounds, you will still be obese. So it doesn't quote unquote cure your obesity. Okay. But 52 pounds of weight loss is a lot of weight loss. Again, through appetite suppression. In the study, same thing. 500 calorie deficit diet plus 30 minutes of exercise 5 days a week. This is not you take Mounjaro and you go about your business. You have to eat less. Sales are just ramping up because it's so new. Even the Mounjaro for diabetes is new. It was only approved, I believe, in 21. So sales were only 280 million in the fourth quarter of 2022, and it costs just over $1,000 for a 1 month supply. So that's going to cost you just over $13,000 a year. Now, pardon me while I fix my lighting here. Okay, so now next slide. There is a tremendous growth in direct-to-consumer targeted telemedicine for weight management and the prescription of Ozempic and Wegovy. So Ro, which you can get like your hair loss medication and your erectile dysfunction medication, depression medication, etc. Ro has something called the Body Program, where they offer a telemedicine consultation with a physician and then prescribing you Ozempic or Wegovy. Okay. Now, Weight Watchers acquired a telemedicine company called Sequence just recently. Again, the same thing. So I'm showing here the technology adoption life cycle curve. This is how new things are adopted in a population. So in other words, in the beginning, you have these early adopters who are the people who are like, hey, I want to try something new. It's a new medication. It might have some risks and some side effects, which, oh, by the way, it's like nausea. It's GI stuff, nausea, vomiting, constipation, diarrhea. Okay, so and some people can't tolerate the higher dosages because the higher the dosages, the more side effects you have. Okay, so the early adopters are like, I don't care about the cost. I don't care about the side effects. Like, I just want to do this, right? And then you have the pragmatists that are like, okay, well, I'll do it if I see my friends do it, right? So pragmatists are very heavily influenced by their peers. And then you have the conservatives that are like, it just needs to be super easy and it needs to be cheap. And then you have the skeptics who are like, no, I'm never going to do this, okay? So all new things follow this. My point is that there's always this chasm between the early adopter and the pragmatists that oftentimes delays the adoption of doing something new. My point here on this slide is that direct-to-consumer telemedicine makes it super easy for the pragmatists and the conservatives to now have access to these medications. So the pharmaceutical companies are not dumb. These telemedicine companies are not dumb. They know that if you can get people because a lot of people are like, oh, I don't want to take off of work and I don't want to go to the doctor and it takes so much time and it's annoying and it's a pain. I'd rather just not do it, right? When you offer them the ease of telemedicine and even home delivery of these things, then that just accelerates the adoption. Okay, now let's talk about the cost projection for a specific employer group, because we have a lot of folks that are involved in employee benefits and employer-sponsored health plans that are on this training session. So let's just take an example of a 500 employee company that has 1,000 lives on their employee benefit plan. They're a self-funded plan. On average, let's just say they spend about $10 million per year in spend. So that's $10,000 for every one of those lives, which is on the high end. It could be this group is probably spending between 5 and 10 million a year in their total spend for their health plan. Okay. So first to do an analysis, you guys say, well, look, we're not going to give these medications to kids that are under 12. So let's just say that only 800 people on this plan are over the age of 12. And then the obesity rate for this group is about 40%. You're going to have some groups that have obesity rates of 30%. You're going to have some groups with obesity rates of 50%. But let's just say that they're at the national average of an obesity rate of 40%. Well, if you take 0.4 times the 800, that means that 300 people within that employee population are actually eligible to take these GLP-1 medications. Okay, so if you go to that technology adoption life cycle, the very beginning of that curve is 2.5% of the population are these early earliest of early adopters. So if you take the 2.5% times the 320 people, that means you're going to have 8 people potentially in year 1 that are on these medications. And what I did was I took sort of the average annual amount for sort of all these different medications and filling them at different pharmacies, et cetera, et cetera. And let's just say that it's about $11,830 per year. Okay, so just under $1,000 a month. Then if you take the 8 times the 11,831, that gets you $95,000 a year that you're going to be spending on these new medications, which if you're spending $10 million a year, that means you're going to see that group's overall medical plus pharmacy cost trend increase 0.9% just because of these medications. If you have 2.5% of the eligible population or 8 people take it. Now, let's say in year 2, the employees, they talk to each other, they talk to their friends, more people start taking it. This is still the early adopters. It's just more of the early adopters, which is 16% total. 16% times the 320 people is 51 people. If you have 51 people on these medications times the 11,831, that gets you $603,000 a year that you are now spending on these medications. That's 6%, a 6% increase in your total spend if you were spending $10 million a year for this group of 1,000. Now, let's say it makes it all the way through the pragmatists, right? Because if you include the early adopters plus the pragmatists, that means 50% of your eligible employees. So 50% of the 320 employees are now taking the GLP-1 medications of Ozempic, Wegovy, or Mounjaro. That's 160 people times the $11,831. That's $1.9 million a year that you would be spending on these medications, which is a 19% increase in your overall trend. Okay, so those are that is a model. Now, there are some employers on this call today that have tens of thousands of lives on their employee health plan. So you can take these numbers, and if you have 10,000 lives on your employee health plan, you would just add a 0 to all these numbers. You would be spending $950,000 in year 1. You would be spending $6 million in year 2. You would be spending $19 million in year 3. Now, let's talk about cost containment options. Remember, whenever you're thinking about cost containment, it's important to think about the healthcare cost equation, which is just the cost per unit times the number of units. In other words, the cost per GLP-1 Ozempic prescription times the number of Ozempic prescriptions. So if you're going to decrease the cost of your pharmacy spend here, you need to either decrease the unit cost, decrease the number of units, or both. So that's a very helpful framework when you're thinking about, well, how do I lower costs? How do I get started? You can think about the unit cost and you can think about the number of units. Okay, so what could you do to lower the unit cost? Okay, you could use a pass-through PBM. Keep in mind, the PBMs, the traditional PBM model of rebate, admin fees, blah, 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 is making money off of these medications. The PBMs want the doctors to take the medications. The PBMs want your plan members to take these medications. The PBM makes more money the more of these medications that are prescribed because they make more rebates. The financial model of the PBM, the traditional PBM, is to get as many people taking as much Ozempic as humanly possible. Okay? A pass-through PBM does not do that. So, I can't predict the future, but if the pharmacy costs for these medications just blows up for employers, this might be a catalyst for more and more movement away from the traditional PBM model. So a sort of unanticipated consequence of these medications is that it might totally shellac the traditional PBMs because all the employers are like, this is ridiculous. And the traditional PBMs are making money hand over fist off of this. And so we got to do something different. Okay. So that's the unit cost. Next, the number of units. Okay. Through prior authorization, we're going to restrict how many people can have access to these medications because we're going to put in a prior authorization process. But keep in mind, again, the PBMs tried to do prior authorization for Humira. How'd that work out? Not so well, right? Because again, the PBM doesn't really want people to not take this medication. They really want people to take the medication. So the entire prior auth process is sold to employers as a way of like decreasing the utilization of the medication. But the PBM doesn't really want to do that. They're not like, if you're a shareholder of that PBM, one of your main metrics is script count. So the PBM is literally telling their shareholders that they want more members taking medications and they want more doctors prescribing more medications. That's what they tell their shareholders. Okay. So now, a more controversial way of dealing with this is through a specialty carve-out. Now, there are self-funded plans that specifically hire vendors that rewrite their plan documents that say this plan no longer covers these particular specialty medications, or in this case, these GLP-1 medications. And then the patients themselves use the vendor to sign up for a patient assistance program through the pharmaceutical company. Now, that is a hugely controversial technique. I am not here to say whether it's a good or a bad idea, but you as an employer might need to ask yourself, do I got to spare $19 million? And if I don't have a spare $19 million, maybe I need to look into that. At the end of the day, just for the Ozempic, again, like, use the 8 milligram pen because, like, if you're going to buy the Ozempic and it's going to cost you $1,000 anyway, then you might get as much Ozempic as possible for the $1,000. Why spend $1,000 on just 2 milligrams of Ozempic? So you can look at your pharmacy spend and like, what are the dosages of Ozempic that we're spending money on? Like, does the PBM have a program that once you're on the maintenance 1 milligram of Ozempic, that you're not taking the 8 milligram pill injection pen? Like, come on, guys. This is not rocket science. You're not like hurting anybody. They're still getting their medication. You're just getting more of it. The resource control, in other words, the inventory control on these medications is historically has been awful. Okay. Think about how much security and how much tracking that companies do for a $500 laptop. It's got barcodes, you're logging in, blah, blah, blah. Here you've got a little pen that costs $1,000. It costs twice as much as a laptop. What if you lose it? What if you place it someplace? What if you leave it at home? Right? So the inventory control, like if you're an employer and you're spending $1,000 on this little pen, what are you going to do to make sure that people don't lose it? I mean, we can't, and why do I make a big deal about this? Listen, am I trying to stop people from getting treatment that's helpful for them? No, of course not. I can't stand waste, because when I think about wasting $1,000 pen, I'm like, do you know how many people that could help? Like, do you know how much healthcare you could donate to a free clinic with that $1,000 of a lost pen? I mean, when I was in medical school, I volunteered at a free clinic in Chicago. I mean, it like it would bring tears to your eyes. Like I'm getting a little choked up about it right now. I mean, it's just, we can't waste it because there's so many people that are suffering that could totally benefit from it. I mean, it's criminal. Okay. So what are my take home points? Listen, weight loss is through appetite suppression. Okay. So you cannot take these medications and eat the same. You cannot. It does not work. Okay. 2, the long-term effects of prolonged use is not known. It's not known. Like, That which gets us to point 3. How long do you got to take this stuff? Forever? Like, we don't know. They actually did a trial where they said, okay, well, let's take it for 20 weeks. And then let's compare not taking it anymore to taking it for longer. And guess what happens when you take it for 20 weeks and then stop taking it? You gain weight back. So, but the people who like keep taking it, they don't gain the weight back. So are we going to have to take this stuff for forever? This hasn't been studied, taking it for forever. We don't know the long term. We just don't know. I'm not saying it has bad consequences. I'm just saying we don't know. Okay. So if half the obese plan members take this in the financial modeling, it could increase your total healthcare cost by 19%. And the traditional PBM model is likely going to be completely ineffective in doing anything to help you to actually fix this problem, because they're not financially incentivized to help you fix this problem. In fact, they make more money the less you solve this problem. And look at Humira. Okay. So Humira, hugely successful. Like, Eli Lilly and Novo Nordisk are just going to follow the AbbVie playbook for Humira to a T because it was hugely successful. Okay, so with that, you guys have put in a lot of wonderful questions and comments. Thank you for those. I will answer them in writing because we've already gone 5 minutes over the 35 minutes. So just keep an eye out on LinkedIn and YouTube, and I'll just put in answers to your questions. If you would like to get more of my videos on LinkedIn, please connect with me on LinkedIn. If you would like to receive my A Healthcare Z newsletter, then email me at ericb@ahealthcarez.com and you'll get my videos Monday through Friday when I put them out. You can also subscribe to my A Healthcare Z YouTube channel. That's an option for you as well. And with that, listen, thank you so much for being here today. I missed you guys last week, so thank you so much for being here. Have a great rest of your day and take care.